Hi, my name is Petra Rivera. I'm a nurse here at Lancaster Regional Medical Center. I've worked here for 12 years. I work in the GI unit. I've been an endoscopy RN now for 19 years of my life, GI certified, and we're going to talk today about colon cancer awareness. This evening we're going to have Patty Martens. She's also a GI certified nurse, share in the conversation. We're going to get into some hard facts about colon cancer, and then after that we will have open questions with Dr. Lazarus, our physician guest. This is we did a conference this fall, and we thought this was really cute. It says "Screen this too." We didn't want to take away from breast cancer, but it is very important to be aware that you have to screen the other end.
So my name is Patty. I work up in the endoscopy department. I've been up there for about 11 years. I really enjoy my job. I really enjoy the people I work with. I enjoy the work that we do. And because it is a serious job, we do take our jobs very seriously. We do find that some comic relief during the day is very helpful. So when our patients come in, we try to put them very much at ease. We settle them into their beds, and while we're doing that, while we're doing the examination, we'll often joke with them, see how they're doing. A lot of jokes can arise because of the experience they've been through with the prep. And so I wanted to share some of the things that we might say to them. But before I do that, I want to applaud you for coming out for this discussion tonight. We find a colonoscopy is a very wonderful procedure. We have in our department been able to prevent colon polyps from developing into colon cancer. So we really feel that we have a life-saving department, and I applaud you for coming out for this discussion and learning more about colon cancer. So just a couple of jokes to start the evening out. A man went in for a colonoscopy. The gastroenterologist came in and examined him and then turned him onto his side to begin the procedure, because all colonoscopies are done on the side. The doctor immediately noticed, because he was very observant, a large piece of lettuce protruding from the gentleman's posterior. "Sir, did you know you have lettuce hanging out of your bottom?" "Oh yeah, but that's just the tip of the iceberg." But I'm going to let Petra go ahead and take over for right now.
Basically, there's about 150,000 people diagnosed with colon cancer every year. 50,000 of those people die every year. It's the second leading cancer killer in the United States. So this is a picture of my mom and myself. The reason I put her there was because it does not discriminate against sex or race. It affects women and men and people of all ages. Who gets it? The single most important risk factor is only age. Like I said before, it doesn't discriminate against race or gender. And another thing to be aware of is that you don't have to have a family member to get it that has had cancer before. It is not just if it's in your family history. People get it with no family history at all. That is very important to remember. The symptoms are no symptoms. Often there aren't any symptoms when you have colon cancer. You don't even realize that you have it. If you do have symptoms, it might be rectal bleeding, unexplained abdominal pain. You might have change in bowel habits. You might have a more narrowing of your stool. Another thing you might have is anemia, weight loss. But again, often there are no symptoms, and that is why it is so important to take care to screen. I was going to put healthy food up there, but instead I decided to put a high-fat cheeseburger. But what you want to do is there are things that you can do to help prevent colon cancer. And for sure one is diet. You can avoid a high fat diet. You can avoid smoking. Do not smoke. Smoke is also a contributor. Avoid excessive use of alcohol. And you should exercise and eat a balanced diet. You want to just eat a balanced diet filled with vitamins and minerals and all the nutrients that you need. And like I said, again, avoid high-fat foods, like French fries, cheeseburgers, anything with high fat.
And make sure you eat your greens.
And the greens, yes. Not just the tip of the iceberg, the whole lettuce. It is preventable, and it can be curable. The only way to prevent it is to be screened. And if you're screened, we can find those polyps that are just starting to grow and then take them out before they grow into a large cancer. So that's how you would prevent colon cancer, is with screening. And the time that you should first be screened is at 50, and that is for men and for women as well, age 50. It's the same for both genders. Also, if you have symptoms, you should be screened. If you're 30 and you have rectal bleeding, you should be screened. Any kind of symptom that you would have that's a change for you, a change in bowel habits, abdominal pain, then you should definitely have a colonoscopy. If you have a family member that has colon cancer, you would want to discuss with your physician the time that you should be screened, because it might be sooner than 50. They might want you to come in a lot sooner depending on the age of your family member that did have colon cancer. So it's important to think of those things. And if you were screened at 50 and you didn't have any polyps or anything, and then a year later you have some type of symptom, you should go back to your GI physician again and say, you know, I'm having rectal bleeding now. Don't just think, oh, I was screened, I'm good for, you know, so many years. Early stages, if it's caught in the early stages, 90% of people can be treated and live. But if the late stages, 10% will be alive in 5 years. And from the American Cancer Society, there's a really nice pamphlet back there that really describes the different stages of cancer and when it's caught. If you catch it in the late stages, less than 10% will be alive in 5 years, which that's the hard fact, and that's why it's very important to be screened at 50. Kathy Ireland is the spokeswoman now for the ASGE for colon cancer awareness. And if you go onto ASGE's website, it gives you a great amount of information about colon cancer awareness. Kathy Ireland has some little videos on there just talking about colon cancer screening and prevention. It's just a wealth of information that you could look up, and it's really interesting to go to that site. But what I was going to say is women too, I know they say 50,000 die, but then on the ASG website they mentioned that 26,000 women die every year. So it's not just a disease that men get, women get it too. This picture, I loved this picture. It basically talks about scheduling a screening if you're 50 or older. And when I looked up these pictures, I felt incredible joy. It's a bunch of older people smiling. And this couple here, it's an older couple on the beach. And it's just basically saying, if you're screened and you can prevent colon cancer and you can catch it early, then you can live a long life. You can save your life essentially by getting a polyp out that could go cancerous. And the only way you're going to know it's there is if you're screened. Patty is going to describe what's going to happen to you when you come to the hospital to have your procedure done, and then maybe we can discuss some different tests.
So let me explain a little bit about what it's like when you come here to our hospital for colonoscopy. And I know that there are freestanding clinics, and it's very similar. The paperwork is a little bit more in-depth here, but the treatment is very much the same. The first thing that you're going to do before you come to see us is you're going to see your gastroenterologist, and you're going to have to take a prep. Now, people find that that is the most distressing part of the entire colonoscopy procedure. A day or two before your colonoscopy, before your appointment to come to the hospital, you're going to start drinking just clear liquids. And then you're going to be starting a prep, probably the day before, and during that evening or the night before you come in, you'll wake up early in the morning and have the rest of your prep. Now we're going toward a split prep, which means you take half of the prep in the daytime and half of the prep several hours before you come in. The prep is, as Dave Barry puts it, like a nuclear explosion of my rectum. It does work. The purpose of the prep is to draw fluid into your colon so that the fluid can then flush out all of the fecal material, because when we get you in here to do your colonoscopy, if we can't see well, we may miss some of those polyps that could then go on to threaten your life. So our whole purpose in that prep, even though it's not fun, and I know I've had 2 colonoscopies, I named my toilet during the second one. It was my friend. The whole purpose is to clean out that colon so that we can see, because if we can't see, we can't give you a good exam. And And that's not a good thing as far as we're concerned. Your colon is about 5 to 6 feet long, generally, and the colonoscopy scope is about that long. So we do have a lot of area to traverse so that we can see. The colon has different unique aspects to it. The ascending colon is a little thicker, the transverse colon is a little thicker, and the descending colon is not quite as thick. Oh, Petra's going to show you a beautiful picture. And what we need to do is we need to, as we go into your anus and then up your rectum, we have to go and traverse that whole area of the colon. I'm going to move here. So we're going to go in here. This is your sigmoid, and we're going to go around up here, across the transverse, and down here. This is where your appendix is. It's also where your small intestine hooks up to your large intestine. Okay? So basically, the goal of the colonoscopy is to examine. We want to get all the way back to that appendiceal orifice and examine your colon to make sure that there are no polyps. There's been a lot of studies published now that the flat polyps that we see as you in the ascending colon can be a little bit more dangerous than the other types of polyps, the polyps that are raised. And so we have to look very hard. We have very special scopes that are high definition scopes. And as we go in, everyone concentrates and we look very carefully to make sure that polyps aren't missed, because we want to give you the best possible look at your colon that we can do. So the prep is the most disturbing, and when people come in to see us, they oftentimes have a lot of stories about their prep, and we're sorry about that, but it is a necessary evil. What we find is that people can sometimes do a virtual colonoscopy where they'll take a little pill that has a little camera, but they have to go through the prep also for that. And then if they do find polyps with that virtual colonoscopy, we have to go in and do a conventional colonoscopy. So we're just very grateful to do the colonoscopies the way that we do them. So what we do is we bring you into our hospital. You're registered down in registration. We bring you up to our endo department. We get you undressed completely. We give you a gorgeous gown that ties in the back but opens so that we can get to where we need to get to. We hook you up to monitors. We assess you from top to bottom. We'll start your IV. And then we ask you a lot of very personal questions. We won't go into that now, but a lot of it has to do with your colon and your stool and all sorts of things like that. You'll be met with by an anesthesiologist or a nurse anesthetist. We take you back into the room. We're going to roll you up onto your side. Oxygen in your nose. The oxygen smells a little plasticky and it feels cold. Medicine in your IV, and the next thing you know, you're back out in recovery area. During the procedure, we insert our scope. We have special apparatuses on the scope. Of course, there's a camera on the end so we can take pictures. Basically, we go through your entire colon. If there is some debris left from the prep not being as good as we would like it to be, we have flushing apparatuses so that we can clear your colon out. And we try to do the best that we can. There are some instances where people's colons don't function as well as they should. They aren't as clean, and so we'll have to bring them back and repeat the prep. After the procedure, the doctors talk with you. If we see any polyps, we take them out. That we just do it that day. And we take all polyps out that we can find. We will be able to tell you that day if we found any polyps. We won't be able to tell you any pathology. Those polyps are sent to the lab. The laboratory people look at the polyps, and they will then send a report to your gastroenterologist. Depending on the pathology that those polyps show will determine when you come back to see us again. Some people come back within a year. Some people come back within 3 years, depending on what the pathology shows. After the procedure, we keep you in our facility for about 45 minutes to make sure that you're nice and awake. We used to have a problem with people feeling very bloated after their colonoscopies, passing a lot of gas, but currently we are now using carbon dioxide in our hospital. The gas is absorbed by the gut, it's expelled by the lungs, there isn't the distension and there isn't the pain. So currently, people are not uncomfortable anymore. We're very grateful for that. We keep you for about 45 minutes and send you on home. That day, you can resume most of your normal activities. You can't drive, you can't have any alcohol because you've been sedated. You can eat whatever you feel like eating when you go home. And we give you discharge instructions and then we send you on home. And hopefully won't have to see you again for several more years. That's about what we do here. Are there any questions that you have for us as nurses before I turn it over to Dr. Lazarus, who will answer all of your medical questions? Yes.
As far as the prep, like the day before, is it that bad that you couldn't go to work the day before? You have to, or obviously the day of the procedure you can't, but
right.
The day before, do you have to take 2 days off with your recommended?
Well, I can speak from my experience. I was off the day before my colonoscopy, and I was grateful for that, because once the prep hits you, you need to be close to the bathroom.
Yeah.
It's very quick.
Yeah. It hit me later, but everybody's going to be different.
Everyone is different, right?
So, I think I could have gone to work that day, but I don't know. Every person is going to be so different with the prep.
It's a great question.
If you have a bathroom at your work that you can easily get to. I mean, if you're out on a tractor somewhere or something. Yeah, if you're in your office with your little bathroom and,
Yeah,
that's fine.
I was grateful to be home. I was actually painting my ceiling. It was like an up and down thing. Up on the ladder, paint one thing, down to the bathroom, so.
Well, we are very thankful to have Dr. Lazarus here. He is from RGAL, and he is a physician that we work with, so we can vouch for what a wonderful job he does. And he's going to come up and answer any questions.
My name is Ben Lazarus. I'm a gastroenterologist, and I'm chief of the division of gastroenterology here at Lancaster Regional. Thank you very much to Petra and to Patty for doing that. It was excellent. But I think it's very important for all of us to know that March is Colon Cancer Awareness Month. Colon cancer is lethal and preventable. And just as Petra has said, that it's very important that some type of screening be completed. Now, any screening is better than no screening, and there are multiple different types of screening that we really didn't talk about other than colonoscopy. Colonoscopy is the primary and best approach for screening for colon cancer, but there are a lot of other things that we use. We use stool tests. We use virtual colonoscopy, which is a computer-based colonoscopy. We used the new Cologuard, which is the DNA stool testing, which tests for DNA of tumors within stool, and we can actually test for that. All of these studies are okay. It's better than nothing, but clearly not as good as a colonoscopy. Colonoscopy in our hands, among the 25 gastroenterologists in Lancaster, is extremely effective. You should start at age 50 again. If you have a history of colon polyps or colon cancer in the family, or there's a history of inflammatory bowel disease, you may need to start sooner. If you have a first-degree relative, mother, father, sister, brother, that has colon cancer, you may need to start earlier. That's a discussion that you need to have with your gastroenterologist about when it's appropriate to begin screening. In terms of the prep that you talked about, you can be on clear liquids for the whole day until 6 o'clock, and then you take the hammer. And at that point, you should be at home and be close to a bathroom. But the prep is not nearly as awful as it used to be. We use Gatorade and Miralax now. It doesn't taste awful, but it does give you a little bit of a wake-up call to go. Colonoscopy is safe, it's effective, and we look for polyps. An adenomatous polyp, which is one of the various types of polyps that we see, is a polyp that can be precancerous. Not all polyps go to become cancer, but we know that all cancers start out as polyps. And there's something called the adenoma carcinoma sequence, where you have polyps of a certain type, And over years, and sometimes they can take as long as 10 years to grow to become a cancer. That's why we go and be very aggressive with colonoscopy to try to get polyps out. Sometimes polyps, because of patients' genetics, can be very quick and aggressive, and you can have a colonoscopy and 3 years later you develop a colon cancer. We see that. It's rare, but it does happen. So I'm going to kind of throw this open now and maybe answer some specific medical questions about how we do it, what to expect. Anything I can answer for you specifically. Yes, sir.
How common is it to have polyps found?
Well, we know that if you do a screening colonoscopy in an average risk 50-year-old, in men, we think it's about 25%, and in women, it's about 14%. And that's the kind of thing that we've been pushing. We look at adenoma detection rates, and we do that here at Regional, and we follow physician per physician, and we know exactly who picks up what, and we are all above the national average. It's been very good here. We take great care. Now, some of the newer numbers have said that we're probably looking at more 30% for men, 20% for women. That probably will change within the next year. But those are the types of numbers that we look at. So it's not unusual to have a colon polyp, especially as you get older, between 50, 60, 70, 80-year-olds. And we don't see a lot of 80-year-olds for screening, but those are the people who will develop colon polyps. And certainly if you have a polyp, you're high risk for developing colon cancer, and those are the people we want to go after. You know, there was a really great landmark article in the New England Journal of Medicine a couple of years ago that kind of verified all of the data that we had been seeing over 20 and 30 years of doing colonoscopy. And I've been doing this for about 30 years here in Lancaster. We've known among the GI community that if you take polyps out, you will save lives because you will stop colon cancer from occurring. The New England Journal finally, with looking at multiple hospitals and tens of thousands of patients, finally was able to verify by data that the death rate among patients who have had colonoscopy has been falling over the past 10 years. So that we know that we are making an impact. We know that what we're doing is saving lives. And its screening colonoscopy has an impact on whether or not you can develop colon cancer and whether or not you can develop it and find it early or not. Finding an early colon cancer can be a cure. Really, colon cancer is really dependent on how deep the colon cancer goes in the wall, from the lining to the outside lining. From the inside lining to the outside lining. If you get a colon cancer that is on the inside lining, there are a lot of techniques that we can do now to actually shell out these things without surgery. And those are cures. If the colon cancer makes it to the outside wall and beyond, that's a bit of a problem. The patients need to have other therapies, chemotherapy, sometimes radiation, sometimes very advanced techniques that we do here to get tumors that have spread beyond the boundaries of the colon, and we do that quite well here as well. So we have to be aggressive and go after these cancers as aggressively as we can. Other questions?
Are colonoscopies generally covered under insurance?
That's a good question. With Obamacare, think of what you may want to think about Obamacare. Personally, I appreciate it. Colonoscopy screenings at age 50 have become part of the preventable screenings that Obamacare has provided, and most insurance companies today will provide a screening colonoscopy at no charge. If, however, you have a colonoscopy and there is another finding, you have hemorrhoids or diverticulosis or something else, there have been some problems with cost and billing. The insurance companies are now understanding that and making changes with how they pay. Certainly Medicare patients all are able to have colonoscopies. It's paid for by Medicare, and depending on your risk stratification, if you have a polyp or a family history, every 5 years you can do that. If you're of average risk, it's every 10 years. So it is something that's being paid for by insurance companies and by the government, and that makes sense on so many levels to develop to develop a screening technique that will save lives, because if you look at patients who have had polyps and develop a colon cancer and then they end up having an operation, visits with an oncologist, chemotherapy, radiation, the actual cost of taking care of that is way more than doing a screening and making sure that we get their polyps. So it makes financial sense, and the government understands that.
We heard that flat lesions are particularly dangerous. Is there some special method for picking those up?
Yes, good eyes. You have to be very astute, and the nurses in our division are highly trained, and everybody watches this giant high-definition screen. What we do is we try to do a very complete colonoscopy. We spend a lot of time looking at all the walls, and we actually decompress the colon. The colon is almost like a balloon, and if you insufflate it with carbon dioxide, it spreads out like a balloon, and it's very difficult to see any of the finer details. As you take some air or CO2 out, it collapses a little bit, and you can actually see subtle differences in the lining. And we have to look very carefully for those. They're hard to find, but we do find them. And when we do find them, we have special techniques now where we can actually take them out. You know, most polyps look like mushrooms, either a mushroom cap or a mushroom with a stalk on it, and those are the easy ones to find and to take out. It's these flat or depressed lesions that are a little bit more difficult to find. Newer techniques now, we do what's called saline lifts, where we'll take a little needle and we'll tease it underneath this flat lesion, and we'll inject saline or a gel or a little bit of methylene blue to color it, and it actually spreads the linings, and it actually makes it look like a mushroom head. And then we're able to get a snare around these things and actually remove them whole. It's a much better technique to take out these polyps. Flat polyps can be dangerous, and because number one, they're not seen, and then you leave people to their devices for 10 years and you bring them back and something bad has happened. So it's very, very important that we have an excellently cleaned colon and that we take a lot of time and look. One of the things that we do here is that we measure what's called cecal withdrawal time. And once we get to the origin of the colon all the way on the right side, we then actually know that there is a minimum time that you can actually pull the scope out to get a good look. And we know by data that if you pull the scope out quicker, you have a less effective colonoscopy. The slower you pull it back, the better look you get, the more polyps you pick up. And we watch that very carefully here, and we monitor all of our physicians. Everybody is well above the national average. So any other questions I can answer? Yes, sir.
So from what you're saying, you insert the tool all the way in, and then as you're backing out is when you're actually doing
That's the best look. Actually is the best look. It'll take, in expert hands, probably about 5 minutes or so to make the 11 turns that we need to make. Sometimes these colons are long and twisted and they don't look like question marks the way a normal colon looks. If you're a 40 or 50-year-old Asian male, you've got the smallest, straightest colon. Sometimes if you're an older person, you've had diverticulosis or you've had surgery, some of these colons can be quite tortuous, and it's the skill of the endoscopist that allows the scope to make it to the right side of the colon, which is where you want to be. Once you're there, then we do washings, and then we're pulling back the scope very slowly, looking at all of the walls, all of the angles behind all the folds, looking for these little ditzels that can grow. The big ones are easy to find. It's the little ones that I think the experts really have a good history with. So that's what we do. The colon is a long tube that does only one thing. It just takes water out of stool and makes wet stool into hard stool. And you don't need a colon. It just makes your stools hard, and it helps you to pass your stools. It's a tube that only feels stretch. You know, whenever you have to go to the bathroom, it's a stretch sensation. Whenever you have to pass gas, it's a stretch sensation. So that when we put scopes in there and we biopsy something, or we use electric cautery, or we fire lasers in there, you don't feel any of that. What patients used to feel when we did colonoscopy was that sometimes we'd have to push through a loop and there would be some stretch. Sometimes we would inflate with air, there would be stretch and there would be pain. It really doesn't happen anymore. With the use of CO2 and the new instruments that we have, which are very flexible, and the skill, I will tell you, of the endoscopist, which is very good in Lancaster, it's very unusual to have a problem. There's always a risk when you do any type of intervention, such as colonoscopy, any type of testing medically. There can always be a risk of a complication, and they're rare. But they do occur. You know, rips, perforations, bleeding, all of those things are rare. The national guidelines tell us that maybe 1 in 1,000 will perforate during a colonoscopy. It's highly unlikely that that's going to happen, especially in our hands in Lancaster. Our perforation rates and our complication rates are extremely low. You know, usually you can have a problem. Sometimes you can find somebody with a very narrowed colon cancer, and when you try to get through that colon cancer to make sure there's nothing up above that, sometimes it can snap open like a rotten sponge on a sink. It's rare, but that can happen. Sometimes if we take out giant polyps trying to save somebody from having an operation, a perforation can be made. Years ago, those patients all went to surgery. Today, we have special clips and special apparatuses where we can actually close perforations at the time of colonoscopy, preventing somebody from going to surgery. So there have been some great strides that have been made. It is a safe technique, but not something that we take lightly. It's something that we're very serious about.
How often do you use that DNA testing of the stool, and do insurances cover?
Well, it's called Cologuard, and it was created at the Mayo Clinic, and it's expensive. It's $500. The problem with Cologuard, not that it's a problem, is that there are some patients who refuse to have colonoscopy. They say, "Oh, you're not going there. Don't go there. Don't go there." But any screening is better than no screening. So we used to do stool tests for blood, and they're not very sensitive or specific. We do something called a FIT test, which is fecal hemoglobins, which is a little bit better. And then now Cologuard, which actually measures DNA, and it's a combination with the FIT test. We know that if that's positive, there's about a 90% chance that you have some big lesion within the colon. Whether or not it's a polyp that's benign or malignant, it can be there. So if you have that done and it's negative, that's great. Every couple of years, you should have that done. In fact, I think the current data on Cologuard is that every 5 years you need to have that done. But it costs $500, and insurances are really not paying for that just yet. If a Cologuard is positive, you have to have a colonoscopy. You just have to. So in the way we look at it is, if you're going to spend $500 to have a Cologuard, just go right to the colonoscopy. Colonoscopy is it's 2.5 hours of an inconvenience. But it's not nearly what it used to be in terms of discomfort and pain and risk.
But, excuse me, the
Yes.
Cologuard will pick up cancers, but it doesn't pick up polyps.
Correct.
So they then become a cancer.
Correct. Cologuard is a great test. It's not one of those things where we're ready to say it's ready for prime time for everybody. Still, the data is not good when you compare Cologuard to colonoscopy. But it's something that is better than nothing. You know, any screening is better than nothing. 20% of the population refuses to be screened. They just won't have it done, any type of screening. And that's a problem because, you know, if you don't screen, you can't find anything. There are 3 types of cancers that can be screened for: colon, cervical, and skin. And if you screen for those things, you can help to save lives. If you don't do anything, well, then you're just going to be surprised. And you don't want to be surprised like this. If you have any specific questions, let me know. You know, we're here at Lancaster Regional. We have a big division of gastroenterology. We're made up of 2 groups, and there's 25 of us in Lancaster. And colonoscopy, upper endoscopy, interventional biliary work. A lot of very sophisticated things are done here at this hospital on a daily basis with great success. Thank you all for coming, and thank you for coming and thinking about screening.
I just wanted to add 3 things. 6% of people will get colon cancer, but the studies that they've done, what Dr. Lazarus was talking about, they've noticed that people that get screened, there's a 5% decrease in deaths since people have been being screened, which is very interesting. That study is on that ASGE website, so that's how important it is to get studied. And then the other thing I wanted to say is, in 2014, there's a thing that we check for, and that's the cecal intubation rate, which is actually how far the physician got into the colon. Our doctors, it's over 95% that they get into that cecum. So they're really getting a good look at your colon. A lot of times when they don't get into it, it's because there was some issue that kept them from it, like a bad prep, maybe surgery. So I think over 95% rate is really good. Another thing, all the doctors here have over 30% adenoma detection rates. For all of 2014, it was over 30% for women and men that an adenoma was found in a polyp. So the rates are very good, and screening is very important. And I'd like to thank you all for coming, and we appreciate that you came out to hear our talk today. Thank you.